Hello everyone, how are you all? Thank you for joining our today's session. So today we are going to discuss some of the sample questions, and we already discussed one class, I think couple of weeks ago. Now we're doing the second class on sample question. So the meaning of sample question is that it will help you to understand how the exam question can come and how you can find out the tricks of an exam question and how to solve questions. It's not only that how you uses your theory knowledge, you need to also understand that what is the specific clue given to this particular question to solve your MCQ. So you need to have a very, very good knowledge on theory, but on the other hand, you should be very vigilant on some of the tricks, some of the traps, and each and everything in the question has some meaning. Sometimes it can help you to diagnose the condition. Sometimes it can help you to answer the particular question. Sometimes it can even make you fall into a trap. Sometimes the question can appear really easy and you might be thinking that, wow, I don't know why this question is coming to exam. But seems like there is some trap in that question, which can easily, you can get distracted by the look of the simple question. So just by getting a simple question, don't just answer promptly. Always think before you answer any question. Read each and every part of the stem very, very carefully. Okay, so let's start our today's session. We discussed some of it already. We'll go to the page that we haven't done yet. So we discussed up to this, I think, in our previous session. Okay, so today we're going to start with this one. So you have been given a blood picture with teardrop cells, okay, high WBC, anemia, and thrombocytopenia, immature granulocytes, and they're asking for what is the most diagnostic investigation. So if you look at this blood picture, what's your most likely diagnosis? If you look at here, you see that there is high WBC count. Getting high WBC should suspect that this patient most likely having leukemia. Okay, or sometimes it could be lymphoma also. We don't know. But then you look at that this patient having high WBC, but anemia and thrombocytopenia, that goes with leukemia, because sometimes the leukemic cells can infiltrate the whole bone marrow and you can develop anemia, you can develop thrombocytopenia. And this is the most important clue here, that you have got immature granulocytes. There are lots of subtypes of leukemia, right? So you have got ALL, CLL, AML, CML. That's the basic subtypes. Which one you will get immature granulocyte? So acute lymphocytic leukemia, acute myeloblastic leukemia, chronic lymphocytic leukemia, or chronic myeloid leukemia. In which one out of these four you might get immature granulocytes? So in case of acute myeloblastic leukemia, so myeloblast means that they are actually like immature, right? So in AML, you will get this sort of immature WBC, which is your myeloblast. In CML, what you will get? Yeah, so mainly you will get like, there are also granulocytes, but more mature granulocytes. Okay, all right. So that's your AML and CML. Now, obviously, by looking at the peripheral blood film, you will understand what type of leukemia it is. Could be AML, could be CML, because it's granulocytes. If it was lymphocyte or lymphoblast, we would think about ALL or CLL. Okay, so obviously it's not ALL or CLL. Acute lymphoblastic leukemia is common in children. So in adult, don't think about ALL mostly. It can happen, but mainly ALL happens in children. CLL is common in adult patient, but you will get lymphocytes or okay, but not granulocytes. AML, CML, you will get granulocytes. AML, you will get more immature one. CML, you will get more mature one. Okay. Now, the question is not about the diagnosis. Question is about what is the most diagnostic investigation. So first of all, you need to know what is your diagnosis before you know what type of diagnosis what type of investigation you are going to do, right? So for this particular diagnosis, what do you think your most diagnostic investigation will be? So you want to do bone marrow biopsy, plasmapheresis, genetic study, cytogenic analysis, or peripheral blood film. All right. We'll discuss about both CML and AML today. Okay. So if you want to know something more about any of this, always go through the e-medicine or Medscape. That will help. If you look at here, in case of approach considerations, the workup for acute myeloid leukemia includes the following. So you have got blood test, which is mainly your peripheral blood film, bone marrow aspiration and biopsy, that is your definitive diagnostic test. You have got analysis of genetic abnormalities and diagnostic imaging. Now, immunophenotyping by flow cytometry of bone marrow or peripheral blood sample can be used to differentiate AML from ALL and also to further classify the subtype of AML. So sometimes you also do flow cytometry to distinguish between AML, ALL, and more importantly, to know the prognosis, to go for definitive management of this patient, you will need a flow cytometry. But if sometimes they ask that what is the most definitive investigation in AML will be bone marrow aspiration and biopsy. Okay, so you guys are all right. Now, about the CLL, or not the CLL, CML. If we go to the CML in here, So in case of workup for chronic myelogenous leukemia, again, we will do complete blood count with peripheral blood film. We will do bone marrow analysis. In this case, mainly in case of CML or CGL, you will get hepatomegaly and splenomegaly, which is very, very important finding. Now, diagnosis of CML is based on the histopathologic findings in the peripheral blood and finding the Philadelphia chromosome in the bone marrow cell. Okay, so in the bone marrow, if you get Philadelphia chromosome, that's your CML. In case of CML, when you do the blood count and peripheral blood film, you will find out increase in the mature granulocyte, and you will get normal lymphocyte count. Okay. In bone marrow analysis, you get hypercellular bone marrow, and mainly in here you will get megakaryocytes prominently. So megakaryocytes prominent in the bone marrow, you should think about CML. Now, you need to also order a cytogenic study of the bone marrow cell, making sure that you get this typical Philadelphia chromosome. This is the hallmark of CML found in almost all patients with the disease and present throughout the entire clinical course of CML. Okay, so the basic thing that you need to understand, if they ask you the diagnostic investigation, in this case, we will go for this bone marrow aspiration and biopsy. But sometimes they can ask you that what will help you to differentiate between like some other form of leukemia, or sometimes even they can ask you which of the investigation below will help you to manage this particular patient. For management purpose, just only diagnosis is not enough. So you need to find out the subtype of this CML or CLL. Okay, so to know the subtype, you have to do the cytogenic studies also, which is also your flow cytometry. Okay, so different. So if they ask diagnostic, then bone marrow. If they ask for the treatment purpose, what is the most important investigation, that will be your cytogenic studies. All right. Next, a 40-week pregnant with blood loss of 1000 ml, tender uterus, no fetal heart rate, blood pressure 98/50, heart rate is 110. What is the next immediate management in this patient? So you want to go for amniotomy, large bore IV cannula, LSCS, so cesarean section, syntocinon, or cross-matching. Obviously, this patient having, if you look at here, it's a tender uterus, no fetal heart rate, and patient is in shock. So this patient is having placental abruption. For placental abruption or whatever it is, when a patient is losing blood and you can see patient going into shock, your main thing to resuscitate this patient, right? So first of all, you need to give IV fluid to this patient. How you give IV fluid? You need a IV cannula. So obviously large bore IV cannula will be your first thing to do. Now let's say you have given large bore IV cannula, you have started IV fluid. Then what you are going to do for this patient? Same option. Very good, Dr. Benish, Dr. Humaira, very, very good, Dr. Moni. Yes, you need to send the blood for cross-matching because she will need blood. So when you insert a IV cannula, the next thing is actually take the blood So this is the basic approach. So you insert a large bore IV cannula. After that, you take a blood. So you take blood for necessary investigation, including the blood for cross-matching. Then you start IV fluid. Sometimes, if it is an infectious cause, then you start IV antibiotic after that. So this is the flow, okay? So this is how you're going to start in here. But this patient obviously need a large bore IV cannula first. Cool. Next, a patient came to order few tests, which her naturopath advised. Okay, you feel these are not necessary tests. What you are going to do? Now, if you feel these are unnecessary, do you want to counsel these tests are unnecessary? You want to do the test, refer to another colleague, or you refuse to do the test? Good. So in here, before refusing to do the test, you should always look for something like, if in the option there is explain the patient that these are not necessary, or counseling the patient is always a better option before refusing something. Okay, so counseling will be your best option in here. Four hours after neck surgery, patient has stridor and shortness of breath. What is your immediate management for this patient? So it's a very important question. And if you look at here, this patient had a neck surgery, right? After having a neck surgery, if someone having a stridor and shortness of breath, what's your most likely thought that what's going on? Wound hematoma. So most likely it's a wound hematoma. So most likely this patient is bleeding inside. And that's why, because it's in the neck, it can compress the trachea. And that's why the patient having stridor and shortness of breath. Someone having a stridor, that means that this patient needs immediate management. Now let's explain this thing a little bit. So if we go to here, postoperative anterior neck hematoma, let's look at this chart first. It will give you a more important idea. Now, first of all, if you get a patient with possibility of airway compromise due to neck hematoma after a neck surgery, you look for some of the sign and symptom. So you're looking for worsening of the neck pain, any asymmetry in the neck, increasing neck circumference, that will indicate that something is building up, right? Change in drain output. So you can't find anything in the drain tube, but patient neck circumference is going up, which means that the drain is not working. And there's the reason the wound or the fluid or even the blood is collecting inside. Neck tightness or hypertension. So these are the early sign and symptom. Someone having this early sign and symptom, you can do these things initially. So you have to obviously pace the surgeon, call for help, or you can also call the rapid response team or emergency trauma team. So any of the team you can pace, alert the operation room, difficult airway cart to the bedside. So these are mainly happening in the hospital. So in the hospital, something having like that, always the operation team will be involved. The surgeon will be involved. Okay. The next step is to do the suture removal. Okay. This is one thing. Another thing, if you see late sign and symptom, these are more important, which means that if you see some patient having difficulty swallowing or drooling, having a stridor, shortness of breath, facial edema, patient heart rate is increased, trachea is deviated, this means this patient is having impending airway obstruction. The important thing that you need to remember that whatever happens, if you see that these symptoms are there, like patient having a stridor, shortness of breath, these things are here, that patient need bedside suture removal. Okay, so you have to open the incision at the bedside. But if you get some time, like this patient, early sign and symptom, if you still have time, you don't need to open the suture here. You will just take the patient to the operation room and then you will remove the suture. So this is the main two difference between this thing. Now, in our patient having a stridor and shortness of breath, you don't have time to arrange the operation room, then paging the surgeon. So you don't have any time. Your immediate management will be removing the skin suture as soon as possible in the bedside. Okay, but if this patient did not have a stridor or shortness of breath, just if you can see the drain output is reduced, neck circumference is increasing, patient having some neck tightness, that patient needs to take to the OT. Now, you can think about why not incubating patient, like not incubate, intubate. Why not intubating this patient? Now, it will be very hard to intubate this patient if you do not remove skin suture, because already patient trachea is compromised, is obstructed. So if you want to intubate this patient, it can cause more harm rather than benefit. So you have to remove the skin suture to reduce the pressure. Once the pressure is reduced, then you can intubate this patient if needed. Now, the tracheostomy or cricothyroidotomy will be an option if you see that after removing the skin suture in the bedside, still patient is worsening. Like patient should be improved when you remove skin suture. Rather than that, patient is worsening and like patient is getting hypoxic, respiratory rate is increasing, more stridor. So that patient will need immediate tracheostomy or cricothyroidotomy. But most of the patient, when you remove the skin suture, they will feel better and you don't need to do that. Okay, clear guys? Also, if you still having any difficulty understanding, go through this. This is a very good one. So you can see these are the early sign, these are the late sign. We already discussed that. So the basic thing that I want you to remember that if you find out late sign and symptom, which means that patient is more like having an increased risk of going into respiratory arrest, that patient should have removal of the suture immediately at the bedside. But if you still have some time, patient is not that bad, that means no stridor, nothing like that, but only this early sign and symptom, send the patient to the OT. Okay. So this one, we will remove the skin sutures. Oh, sorry, not this one. This one. So 4 hours after the neck surgery, patient having a stridor and shortness of breath. This is our immediate management at this time. So similar kind of question, if you look at here, 4 hours after neck surgery, patient complaining neck pain. On examination, there is increased neck circumference and decreased drain output. What is your immediate management? Just we discussed about it, right? So what do you want to do for this patient? Do you want to do removal of the skin suture, intubation? Now this patient will need to go to the OT. So understanding is really important, that what is the situation? Depending on the situation, we will act. Sometimes in place of skin sutures, they can give you removal of a staple. The same thing, right? Staple or skin suture, whatever it is, you need to remove. One week after appendicectomy operation, 45-year-old male having diarrhea and pararectal tenderness. What is your diagnosis? So patient had an appendicectomy operation, right? Now 45-year-old male having diarrhea and pararectal tenderness. So do you think that pelvic abscess, acute gastro, subphrenic abscess, and anastomosis leak? Now look at the thing. This patient had an appendicectomy. After appendicectomy, this patient having diarrhea and pararectal tenderness. This pararectal tenderness is a very important clue to your diagnosis. Yes, very good, Dr. Shoikat, Dr. Akram. So you understand in here that why there is pararectal tenderness. Now, have a look in here, like anastomosis leak. It's the most likely one because it's 1 week, but again, it doesn't go with pararectal tenderness. Anastomosis leak patient usually have fever. That's very important. Fever, abdominal pain, those are more common rather than having a PR tenderness. If we look at here, let's go to this link. So intra-abdominal abscess sometimes happens because of other conditions such as appendicitis, diverticulitis. Many cases, however, happen after surgery. And most of the time, these are bacterial infection, most likely E. coli. What are the common symptoms of abdominal abscess, especially your pelvic abscess? So patient would have fever, tummy pain, or abdominal pain, just pain, lack of appetite, nausea, vomiting, change in bowel movement, which is mainly patient with pelvic problems. Like I would say pelvic abscess, patient usually have diarrhea. Rectal tenderness is also common. So we have got both of these, right? Pararectal tenderness and change in bowel movement. And also, apart from that, someone having intra-abdominal abscess, there is increased chance that you will get abdominal pain, persisting diarrhea. You can get fever, high level of leukocyte and C-reactive protein. And usually how you diagnose this patient, you can do just an ultrasound, which will confirm your diagnosis. And this patient will need broad spectrum antibiotic, mainly cefotaxime, gentamicin, and metronidazole. Now, just because this patient had an appendicectomy operation, patient having diarrhea and parectal tenderness, remember one thing, acute gastro doesn't cause parectal tenderness, and it's nothing to do with like the post-surgical patient. Anastomotic leak can happen, but more commonly this patient would develop abdominal pain, fever, nausea, vomiting. Those things are more common. If any time you get diarrhea and parectal tenderness, it's better to choose pelvic abscess because these are more common in pelvic abscess. Now, again, it's not very common with this 1 week time period because abscess mainly happens after 10 days. But again, it can happen in like 7 to 14 days time period. So you have to just look into the symptom and sign of the patient. If we get parectal tenderness, we would always go for something pelvic. And look for some other features in this case, because most of the time this patient will have fever and also like sometimes abdominal tenderness can happen also. Next, a patient with claudication in the left cuff. On examination, all peripheral pulses palpable on the right side. Left side, all pulses palpable, but dorsalis pedis weak and hardly palpable. So in the left side, this patient having peripheral arterial disease. Bilateral weakness of the ankle reflex and loss of sensation in the foot. So when we get that, we also think about neurogenic claudication, right? So this patient most likely having both vascular plus neurogenic claudication. ABI on the right side is 1, but the left side is 0.75. Normal person, the ABI should be in between 0.9 to 1.1. So obviously in the left side, this patient having peripheral arterial disease or vascular claudication. What is your next appropriate investigation? Now the question becomes that this patient having both neurogenic and vascular, which one is more important? Now remember, vascular are more important because this can lead to like a rapid amputation for this patient. Whereas neurogenic claudication will not cause like sudden paralysis of the body. It's not like that. Okay. Now, always when you get a patient with both neurogenic and vascular, vascular will be our first priority. So in this case, they're asking what is the next appropriate investigation. You want to do conventional angiogram, CT angiogram, CT spine, EMG, or arterial Doppler ultrasound. So next should be always arterial Doppler ultrasound. So now in here, if it was a venous Doppler ultrasound, what would be your next option? So B, right? Good. So in that case, you will go for a CT angiogram. Now, sometimes you can get confused between A and B because both of these two can be done. When we do CT angiogram, if in this question, they would ask you what is the most appropriate investigation, that would be CT angiogram. Now, 0.75 ABI is not that bad. Okay. So if we look at here, we always do color Doppler ultrasound. Some people will say that this patient already, we have done ABI. So do we need to do a Doppler ultrasound? Yes. ABI and Doppler ultrasound is different. Now, you can use ultrasound to measure the ABI, that's okay. But color Doppler ultrasound also looks for severity and degree of stenosis, and also the site of stenosis. So we need to know where is the stenosis, where is the block, right? And that you can find out by the color Doppler ultrasound. Now, angiography is the gold standard, and it is reserved for proposed intervention. So that's the important thing. You only do conventional angiogram if you think that this patient needs intervention. Which patient needs intervention? So patient whose ABI is less than 0.4, patient who is having severe resting pain or severe rest pain due to peripheral vascular disease, having ulcer or gangrene, these are the patient needs urgent intervention. That means this patient will need vascular access. So maybe this patient will have a bypass or stenting. So only for those patients, you will choose conventional angiogram. For all other patients, if they ask you what is the appropriate investigation, that will be your CT angiogram. Clear? But in this case, they are asking for next appropriate. So we are going to do an arterial Doppler ultrasound. Next, patient had a motor vehicle accident, presence with blood at the meatus, with inferior pubic rami fracture on the X-ray pelvis. What is your next appropriate investigation? So this patient having pelvic fracture, also this patient having blood at the meatus, which means this patient having urethral injury. Yes, arterial duplex is same as arterial Doppler, same thing. Duplex Doppler, these are all okay. So this patient having a motor vehicle accident followed by urethral injury with pelvic injury. They have already done an X-ray pelvis. What is your next appropriate investigation? So next appropriate, you want to do urethrophy, you want to do CT urogram, trial of urethral catheterization that should never ever be done because this patient having suspected urethral injury, so that's contraindicated. Cystoscopy, again, it will be more traumatic for this patient, so don't do that at the moment. So between A and B, what do you want to do? Next, urethrophy or a CT urogram? Okay, look at this one. This is your Kaplan step to seek a surgery. Urethral injuries occur almost exclusively in men. Sometimes it can be associated with a pelvic fracture and may present with blood at the meatus. Sometimes you can also get a scrotal hematoma. The key issue in any of these is that a Foley's catheter should not be inserted because it might compound an existing injury. But a retrograde urethrogram should be performed instead. Okay, so we are going to do a retrograde urethrogram. If Foley's catheter placement has been attempted and resistance met, this should be a clue that a urethral injury may be present and attempt should be aborted. Sometimes this patient can have bladder injuries, which can be associated with pelvic fracture, and you can diagnose it by doing a retrograde cystogram or a CT cystography. It's not CT urogram, we do CT cystogram. Okay, it's a little bit different. So you are only looking for the bladder injury in this case. Now, in here, if there was an option of retrograde cystogram, that would be a better option. Because when you do retrograde cystogram, you're looking for urethra, you're looking for bladder, both. But in here, there is nothing like that. So next appropriate, we are going to do a urethrophy. But my belief that in any of the other options, there you can get a retrograde cystogram. If you get retrograde cystogram, choose that. Or even a CT cystogram or cystography, choose that. In a stable patient, this is from your e-medicine. In a stable patient urethrophy, mainly we do retrograde one, is the gold standard to diagnose urethral tumor. This is usually performed with a 20 to 30 ml of water-soluble contrast media using an aseptic technique with intravenous antibiotic prophylaxis to prevent contamination of fracture hematoma. So usually you insert a water-soluble contrast. If you look at here, in this guideline, you will get more better understanding about this urethral and pelvic injury. So pelvic fracture from high energy blunt force trauma can cause injury to the posterior urethra, known as pelvic fracture urethral injury, which is most commonly associated with the unstable pelvic fracture. Pelvic fracture urethral injury should be suspected if a patient with pelvic trauma has blood at the meatus. So our patient also having that, right? And a retrograde urethrophy should be carried out if the patient is stable. So this is our answer. Retrograde urethrophy should be carried out if our patient is stable. Once the urethral injury is confirmed, urinary drainage should be established promptly by placement of a suprapubic tube. Okay, normally, if you see that in the retrograde urethrogram, there is urethral injury, you will go for a suprapubic tube. Let's go to this chart. So you're having a suspicion that this patient might have pelvic, what was PFE1? Sorry, I just forgot. So if you see someone having pelvic fracture urethral injury, if you suspect someone having this pelvic fracture urethral injury, then depending on the stability of the patient, treatment will be different. If it's an unstable patient, you are not going to go for a retrograde urethrophy, rather you are just doing a suprapubic tube. Okay, so make the patient first stable, do the SPT, suprapubic tube, then think about doing a retrograde urethrophy. But our patient is stable, so we are going to do a retrograde urethrophy in this case. If you get extravasation, that means when you insert the dye will get out of the urethra because of the urethral injury. That's extravasation. During that time, if you see that there is an accompanying rectal or bladder injury, then you go for open realignment. You don't need to know anything about it. You are just going for a surgery. Just remember, you are going for a surgery after that. Okay, these are not needed. Clear? So in this case, our patient is stable. Our patient having, obviously, we can see that it's a pelvic fracture, urethral injury, right? In that case, our next appropriate investigation will be retrograde urethrogram. Patient with epigastric pain, abdominal tenderness, rebound tenderness. There is no bowel sound. He did binge drinking last night. What is your cause? So, patient presenting to you with epigastric pain, right? There is abdominal tenderness, rebound tenderness, but no bowel sound. Also, there is a binge drinking history last night. So options are acute pancreatitis, duodenal perforation, gastric perforation, gastritis. Now, always gastric perforation is not very common, so rule that out. Gastritis will not cause rebound tenderness or absence of bowel sound. Only between A and B you need to choose. Okay, now let's just go into that. This is for pancreatitis. Pancreatitis patient has a sudden onset of severe, constant, deep epigastric pain, last hours or even a day. Sometimes it can radiate to the back and relieved by sitting forwards. Patient can have nausea, vomiting as well. The important thing about acute pancreatitis is that patient will have more symptoms rather than more signs, which means that there will be more symptoms of severe abdominal pain, nausea, vomiting, but when you will palpate the abdomen, there will be relative lack of abdominal signs. So what are the signs you can get? Patient can have tenderness in the epigastrium, lack of rigidity, guarding, or rebound tenderness. So that's one of the important findings that you want to think about. So patient of pancreatitis usually doesn't have rigidity, guarding, or rebound tenderness. Reduced bowel sound can happen only if patient develop ileus, which is not always present. Okay. Now, depending on that, if you see this patient having epigastric pain, abdominal tenderness, rebound tenderness, and there is no bowel sound. He did a binge drinking last night. What can be the cause? Now, again, it can be difficult to diagnose this or differentiate between these two. Why? Because if they would give you rigidity guarding, that would be more appropriate for duodenal perforation. Okay, so in this case, patient only having epigastric pain, and this one, abdominal tenderness, we need to know that is it a epigastric tenderness or the whole abdomen is tender? Is it this tenderness is only on the epigastric region or all over the abdomen there is rebound tenderness? That is very important to know because that will help us to differentiate between this pancreatitis and duodenal perforation. Having a binge drinking can be a clue to the pancreatitis also, because pancreatitis, many times they usually give this clue to diagnose pancreatitis, that someone having a binge drinking overnight and now coming to you with epigastric pain, tenderness. So that can go with pancreatitis also. So in the exam, if you find out that this patient having only symptoms in the epigastric region, or even rebound tenderness in the epigastrium, then think about pancreatitis rather than perforation. But if the whole abdomen is tender, okay, there is rigidity, there is guarding, then you think about perforation. So depending on the full scenario, we have to either choose pancreatitis or duodenal perforation. Yes, just because this patient having rebound tenderness and absence of bowel sound, we would keep it as a duodenal perforation just because of that. But again, remember, rebound tenderness can happen in pancreatitis also. It's not always absent. Rebound tenderness can be there in pancreatitis, but guarding rigidity is very unlikely. So like if you look at here in the NCBI, pancreatitis can cause rebound tenderness. If inflammation of the pancreas irritate the peritoneum, that can cause rebound tenderness as well. So if pancreatitis causing peritoneal irritation, that can cause rebound tenderness. But again, absence of bowel sound is not very common. So keep it as a duodenal perforation for the moment. Again, be very vigilant in the exam that they will not give you something which will contradict. Obviously, you will get something more which will help you to differentiate. Yes. Now, absent bowel sound can happen due to paralytic ileus, but again, that's not usual features, and also that's late sign. It's not like initial sign. That's why we also need to know when this pain started. So some of the important information is missing. That's why it's a little difficult to say that is it a pancreatitis or duodenal perforation. But again, obviously in the exam, if you get the whole abdomen is tender, there is no bowel sound, we should go for perforation. If it is only epigastric region, every feature is in the epigastric region, then better to choose pancreatitis. Okay, look for that where is the tenderness. It's very important to understand because in case of perforation, patient whole abdomen will be tender, no bowel sound, guarding rigidity rebound tenderness will be there. Two-year-old child with cough and shortness of breath. On examination, there is inspiratory stridor and cyanosis positive. What is your management? So 2-year-old child having cough, shortness of breath, and inspiratory stridor. Inspiratory stridor means it's croup, right? How we remember? Because if it is an expiratory stridor, E for epiglottitis. Also, you have got cyanosis in this patient, which is a feature of severity. So do you want to go for nebulized adrenaline via mask, 100% oxygen via face mask, or just an oral prednisolone? So croup means that it's common cause of shortness of breath and stridor in children. Patient usually have this harsh, brassy or barking cough. It's mainly caused by parainfluenza virus. Usual presentation that patient usually will have this viral flu-like illness for 2-3 days, followed by patient will develop cough, shortness of breath, and stridor. Now, the treatment depends on the severity, mild, moderate, or severe. Normally, severity we define by the change of mental status of the child. We also look for any features that can show that this child is having severe respiratory difficulty. What are those? If child is getting drowsy, lethargic, or altered level of consciousness, that's severe. If child is having cyanosis, hypoxia, hypoxia is not very common in croup, but if it happens, then it's severe. Okay, so cyanosis is a very important feature of severe croup. So this patient will need adrenaline. If it was a case of moderate, then we can only give oral prednisolone. Give it a read from JM as well, just to find out the severity of croup. Okay, I'm not going into that, but I can just show it to you. Just give me 1 minute. So if you look at here, this is the scoring of croup, grade 1, grade 2, grade 3. Grade 3 is the severe. If you see marked respiratory distress, which is patient getting irritable, pallor, cyanosis, tachycardia, or exertion. The most important out of everything is that if the child is getting like lethargic or drowsy. Okay. Also, if child getting irritable, restless, and agitated, that also leads to severe croup. In those cases, adrenaline is the first line treatment. So we give nebulized adrenaline 1 in 1000 solution, 0.5 ml per kilo per dose. That's important. Sometimes they even ask you the dose of this nebulized adrenaline. With nebulized adrenaline, you can also give IV or IM dexamethasone. In case of moderate means that child doesn't have mental status problem, child doesn't have cyanosis, irritability, child has a stridor with some chest wall retractions. In that situation, patient obviously need admission to the hospital, and you can just give oral steroid. You can give either dexamethasone or prednisolone or budesonide. You need to observe this child for 4 hours in the hospital. If after 4 hours child is getting better, then child can go home. In mild group, child even doesn't have any chest wall retraction, just a stridor. Okay. In that case, child can go home if parents are confident. You can even give the parents oral steroid to take at home if the child develops chest wall retraction during staying at night in home. So that's mainly the treatment for croup. Next, elderly man with ear pain. Patient is a smoker and alcoholic. Where to look for primary cancer? So you want to look for primary cancer in tongue, teeth and gums, posterior nasal canal, lymph node, or salivary gland. This case is mainly that you found out patient having referred pain in the ear, right? Referred pain in the ear. What is the most common cause of primary cancer that can cause referred pain to the ear? Now it's given in your JM. So remember one thing. So JM has a lot of information which we don't care sometimes. So that's why always look at the differential diagnosis, look at the serious disorder which you cannot miss. If you look at the JM in the ear pain chapter, you will find it out. So cancer of other side can cause referred pain to the ear. Most importantly, tongue and nasopharynx. Okay, these two is your main one. Sometimes tonsillar cancer can also cause referred pain to the ear. So as always, it is important not to overlook malignant diseases, especially the obscure ones, such as cancer of the tongue, palate, or tonsils, which cause referred pain. Yes, nasopharyngeal cancer can also cause pain in the ear, but more common, tongue. Now, how to differentiate? Sometimes in the exam, they can say that you have done, like, you have checked the mouth, but there is nothing you have found. That means that they are ruling out tongue cancer, because if you check the mouth, you should get the cancer, right? You should get something in the tongue. So if that is there, then you would think about nasopharyngeal cancer. But in this case, we will go for tongue cancer. A 35-year-old man with mucus diarrhea for 1 month. 2 months ago, patient took amoxicillin. Parectal only mucus discharge. What is the cause? So you have got 35-year-old man with a mucus diarrhea for a month. 2 months ago, patient took amoxicillin. And in the parectal exam, you get only mucus discharge. What is your diagnosis? So antibiotic-related colitis, Crohn's disease, ulcerative colitis, villous adenoma, colon carcinoma. 35-year-old having a colon cancer is not very likely. Villous adenoma doesn't cause mucus discharge. Mainly, even if it causes, it can cause parectal bleeding. But most of the time, this adenoma or polyp doesn't cause any symptom. Then we have got 2 inflammatory bowel disease. So IBD, usually they should cause bloody diarrhea, sometimes abdominal pain. And in the parectal examination, you might get anal fissure, skin tag, you can get fistula, all are possible finding, more with the Crohn's. So it's unlikely, and most importantly, this patient had a history of antibiotic use. Even if it's 2 months, up to 3 months, there is a possibility this patient can get antibiotic-related colitis, which is pseudomembranous colitis. But it's not very common just to get mucus diarrhea. Patient usually get watery diarrhea mainly. Sometimes mucus can be there as well. But because of the amoxicillin uses and doesn't go with other option, we would keep it as an antibiotic-associated colitis. There is a lot of link given in here. If you want to read, just give it a read from here. So if you look at it here as the ulcerative colitis mainly involve the colon, and it begins in the rectum, then it involves proximally. The main symptom for ulcerative colitis is bloody diarrhea. Sometimes they can ask you which one has more risk of having colon cancer, ulcerative colitis or Crohn's? What you will choose? Ulcerative colitis. Good. Yeah. And in case of Crohn's disease, patient usually present with colicky abdominal pain. So if patient presents with bloody diarrhea, more commonly chance to have ulcerative colitis. Patient having abdominal pain with bloody diarrhea or mucus, most likely Crohn's. All right. Let's take a 10-minute break now. Then we'll go into the other questions. Okay, so 10-minute break. All right, guys, let's start again. So you have got a lady, let's say it's a 45-year-old, 45-year-old lady having fine tremors in hand on long-term treatment. Someone's microphone is on, sorry. Okay, so you've got a 45-year-old lady who is having these fine tremors in her hands. Patient is also on long-term treatment with lithium and carbamazepine. What's your most likely cause? So lithium, carbamazepine, benign essential tremor, or early Parkinson. Now remember, Parkinson usually doesn't cause fine tremor. Usually it causes a kind of resting tremor, which is coarse. So you can easily rule that out. Benign essential tremor is more common in elderly patient, but it can happen in other group as well. But benign essential tremor patient, usually, if you look at your JM, you will find out some other features. So in case of essential tremor, it's like it could be postural or action tremor, like when you are trying to hold something, like let's say you are trying to hold a cup of like a glass of water. During, like when you try to hold it, you are acting against the gravity, right? Which is, and at that time, if the patient have tremor, that's mainly action or postural tremor. Patient with essential tremor doesn't have any other underlying cause. Patient with their tremor in the hand, they can have head tremor known as head titubation. And most commonly, they have this positive family history. Sometimes in the exam, they can also give you a clue that this tremor gets better after drinking alcohol. Okay, so all of these are features of essential tremor. Some other form of tremor, like you can get tremor in cerebellar problem. In cerebellar dysfunction, you will get intention tremor. Like it's mainly intention tremor means that, remember you do this finger nose testing. So during finger nose test, you ask the patient to touch the patient nose and touch your finger. So when the patient try to touch your finger, that time patient tremor gets a lot worse. Okay, and sometimes patient even cannot touch your finger and they past point. So that is intention tremor with past pointing, mainly present in cerebellar dysfunction. With that, you can get ataxic gait. Patient can have also Romberg positive. Patient can have nystagmus. So all these can be happening in cerebellar problem. In Parkinson, you will get resting tremor, which is also this kind of coarse pin rolling kind of tremor. With that, you can get bradykinesia, rigidity, and postural instability. So patient with Parkinson, they become very slow. So that's why they are having this bradykinesia. They can also having this stooped posture, postural instability, and they becomes very rigid. Okay, kind of lead pipe rigidity, and you will get resting tremor. So these are main causes of tremor. Now, essential tremor or action tremor can happen due to drugs also. So what are the main drugs that causes tremor? If you look at here, it could be related to any substance withdrawal, like alcohol withdrawal, opioid withdrawal, stimulants withdrawal. Sometimes illicit drugs can cause it. Benzodiazepine withdrawal can cause it. Then sympathomimetics, any adrenergic drug can cause tremor. Beta agonist like salbutamol can cause it. Lithium is very important cause of tremor. Phenothiazine, valproate, and amiodarone can also cause tremor. Okay. Now, carbamazepine can also cause tremor. If we look at here, let's see. Okay, I think I haven't kept it here, but what I wanted to tell that carbamazepine can also cause tremor, but mainly carbamazepine causes tremor when you give lithium with carbamazepine. Okay, but if we want to choose between carbamazepine and lithium, we should choose lithium first. Now, as you can see, I have kept a lot of things about tremor for you guys to read about. So please give it a read from your software, those of you who are in our course group, so you know that how to get access to these notes. So please read these things so that you understand it. Okay, it's very important. Now, have a look at the lithium-induced tremor. So lithium-induced tremor is a common side effect, can happen early, even after many years of exposure. When manifesting early, it can be a fine tremor that can even occur at rest. Sometimes this fine tremor can get complicated with an action tremor later on. Okay, so typically occurs when lithium therapy is started or sometimes dose is increased. So kind of fine postural tremor you will find out. Okay, so that goes with our option also. So we've got a fine tremor who is on long-term treatment with lithium. So we'll choose lithium in this case. But there is a lot of thing to read about from tremor. So I'm not going into detail. We will discuss it in our neurology class, but please give it a read from here as well. It's very good. And if you go to the neurological dilemma in JM7 chapter 33, you will get everything written very well in that chapter. Next, a 30 years old female presenting with hirsutism. What is the causative drug? Valproate, sertraline, selegiline, which is a monoamine oxidase inhibitor. Sertraline is SSRI, as you know. Valproate, you know, it's a anticonvulsant. Spironolactone, you know, it's a diuretics. So, which one among these four causes hirsutism? So first of all, rule out spironolactone because spironolactone sometimes is used to treat hirsutism. Okay, so rule that out. Then among these three, it can be hard to find out because none of the given medication causes hirsutism that much. But I have found it in the ETG guideline that if you look at here, hirsutism results from excessive androgen from ovarian origin, which is mainly related to polycystic ovarian syndrome. That's the most common cause. Sometimes it could be idiopathic, that means no known cause. Sometimes less common causes, it could be related to congenital adrenal hyperplasia, could be androgen secreting tumor from ovary or adrenal gland. Cushing syndrome is very common. Exogenous steroid can cause it, and sometimes sodium valproate can cause it. So that's one of our options, right? Go through this guideline in the NCBI. You will have a very good guideline about the hirsutism, how to investigate this patient and treat. The drugs that commonly causes hirsutism, usually we remember by AMD COP, which is A means androgen, M means minoxidil, D means digoxide, C is cyclosporin, OCP, which contain progestin, and phenytoin is most common. Okay, but none of this is in your option. Sometimes remember steroid can cause it also. So among this option, we will choose valproate. Next, postpartum mother with marijuana abuse. So it's a postpartum mom with a marijuana abuse. Mother wants to exclusively breastfeed her baby for 4 months. What is the most appropriate advice on discharge? Now, avoid smoking indoors, smoke after breastfeeding, marijuana doesn't pass in breast milk, advise formula feeding, advice if it impairs her child care, child protective authority might be involved. Yes, who is KL? What's your full name, doctor? One of the all right, Dr. Lama, yes, OCP is given for PCOS, but that OCP is like not all OCP is given for PCOS. There are particular OCP which we give, okay? But important thing is OCP which contains certain kind of progestin can cause hirsutism as well. So usually when we give it, we give like there are lots of combination of OCP, okay, but we try not to give some of the progesterone which can cause more hirsutism. Now, oral contraceptive pill will contain progesterone, but that there are lots of combination of progesterone and estrogen which doesn't cause hirsutism that much. Okay, now in this patient, marijuana, remember one thing, marijuana can pass through the breast milk. So someone having this marijuana abuse, and if she cannot quit, then she cannot breastfeed her baby. Okay, so that's really important to understand that if someone is breastfeeding, like why she's here mainly, that you need to understand that mother wants to exclusively breastfeed her baby for 4 months. Her main concern is breastfeeding. Okay, and they're asking for what is the most appropriate advice on discharge. About the breastfeeding, what you can advise? In my perspective, it's more important to tell her not to breastfeed. So if that is in the option, that avoid or advise not to breastfeed her, that would be the best option. If that is not in the option, then you can advise formula feeding, because that will not impair with the marijuana abuse. Because you need to understand what's her main concern now. Her concern is breastfeeding. Now, if you don't advise something on that, and if she continue to breastfeed, the child can have a lot of other complications. Like child can develop mainly problem that happens that child develops brain developmental issues, child develops lots of respiratory tract infection, increased risk of asthma, lots of complication. Now, very good question. Someone on a long-term marijuana, it's unlikely that they will quit totally, and you cannot ask someone to quit just now, because that need, if they want to do that, we can do it by doing this like doing detox at hospital, but most of them, they don't want that. So gradual reduction of marijuana can be done, but mainly the marijuana abuse treatment is drug rehabilitation center. That's the main treatment. Okay, there is no treatment like someone trying to quit smoking. We can give something like nicotine replacement therapy, but we cannot give any medical marijuana to help them to quit marijuana. So that needs a lot of time. But marijuana stays in the body or even in the breast milk at least 6 to 7 days after smoking. So if you want to know that how long she cannot breastfeed, I would say at least 7 days after stopping the marijuana, she should not breastfeed. Okay, so even she avoid smoking indoor, her blood has marijuana, so that will go to the breast milk. Okay, so mainly adipose tissue, fatty tissue, they can reserve marijuana. So obviously in the breast milk, there will be more marijuana, and more dose of marijuana will pass into the child through the breast milk. So it's very important not to breastfeed during this marijuana abuse time. And also option E is very, very good option, because at the moment it's not important, because nothing has given that mom cannot take care of the baby. So it's not very important, but this will be our next best after advising formula feeding. Okay, but in this case, advising something about the breast milk will be more better option to choose. Normally, we don't advise anyone for formula feeding, but this is one of the case that there is no other way. If we look at here, so a study in the pediatric confirms that THC, which is the active component of marijuana, can transfer into breast milk. So bottom line is, if you are breastfeeding, do not use marijuana. Even someone having, like, mother is not smoking, but if maybe someone in the house smoking marijuana, that can also cause problem, because that mother can have passive smoking. That passive smoking can cause trouble in the baby as well, because if someone is smoking marijuana beside you, and if we test your urine for marijuana, you will be tested positive. Okay, so even passive smoking can cause passage of marijuana to the baby through breast milk. And it's not Australian guideline, it's mainly American guideline. If in American guideline, it's if a mother is pregnant or breastfeeding and there is still using marijuana, you need to report to the Child Protective Authority, because there is an increased risk of the baby with mother doing this drug abuse. But in Australian guideline, I haven't found anything like that. This is the American guideline. This is the Australian one. Give it a read. Okay. A couple going for consanguineous marriage with previous multiple miscarriage history. What is your most appropriate next step? So consanguineous marriage means that marriage in between the relatives. When this sort of marriage happens, there is an increased risk of some of the recessive genetic disorder can get full-blown genetic disorder. Okay, because many of the relatives carry recessive genes. Because they marry, normally they don't marry in any relatives, so they remain recessive always. But sometimes if marriage happens between cousins or anyone who is relative, there is a, like, then they can share two recessive genes, and their baby can get full-blown homozygous state of the genetic problem. Okay, that's the main issue. So, and also they are having increased risk of early pregnancy miscarriages. So for those cases, what is your most appropriate next step? Send for genetic counseling, arrange genetic testing. Non-invasive prenatal test can detect abnormalities. Now, NIPT can detect abnormalities, but it cannot detect all genetic problem. It only detects some of the particular one, especially trisomy 21, 18, the common chromosomal abnormalities. The rare one, they cannot detect. Risk in consanguinity is not so much. So nothing to do now. No, there is risk. There is increased risk. So before sending anyone for genetic testing, it's always important to send them for genetic counseling. In genetic counseling, counselor usually gives them the pros and cons of doing genetic testing. If they understand everything and they are happy with the testing, then we do the genetic test. Okay. Next, mother presents with baby 3 weeks old, cleaning washroom and baby many times. What is the management? So 3 weeks old, so obviously it's a postpartum. Now, mother cleaning washroom and baby many times. What do you think going on in here? Do you know what is the condition called? Yeah, postpartum OCD. Very good. So postpartum OCD is not very commonly diagnosed, but mainly it is common finding, but sometimes we miss it. So postpartum OCD is similarly treated just like OCD anytime. So what is your main management for OCD? CBT, parental education, supportive occupational therapy. That will not help. Okay, so rule that out. Exposure and response therapy. So CBT is the main treatment, but not all CBT. There is a particular name for that, which is your option D, exposure and response prevention therapy. Okay, now in here, if there was SSRI, would you choose SSRI or exposure and response? Yeah, so D first. Very good, Dr. Riveti and Fatima. So obviously, because remember one thing, RSEGP says that they have equal efficacy, sometimes even more. Okay, so always start with the exposure and response therapy. Okay, so the strongest evidence in OCD is the CBT and SSRI. For the CBT, the substantial evidence is exposure and response prevention, ERP. Next, 5 years old girl brought by mother with some incidental finding. You have got a swelling just above the umbilicus. No symptoms, unpalpating, soft and non-tender. The picture swelling was around 2 centimeters only. Now, I don't know what type of picture it is. So I'm going to discuss each and everything, but lipoma and epidermoid cyst is not very common. Usually in children, if hernia comes, more common is umbilical hernia, paraumbilical hernia, epigastric hernia, and inguinal hernia. Okay. So now, if you look at here, it's just above the umbilicus. So obviously it's not umbilical hernia that we can say, because umbilical hernia should not be above, it should be in the umbilicus. Okay. Now look at some of the pictures. If you look at here, you can easily understand. You can see the umbilical hernia here. Okay, so that involved the umbilicus, right? And you can see the umbilicus is kind of everted. Paraumbilical hernia, you can see the umbilicus, and it's not everted, it's just above the umbilicus in here. Now in the picture, if you find something like that, then you will choose paraumbilical hernia. So how to differentiate between these two? In umbilical hernia, umbilicus will become everted, but paraumbilical hernia, umbilicus becomes crescent shaped. Okay. So usually in parumbilical hernia, herniation occurs through linea alba above or below the umbilicus. And in umbilical hernia, abdominal content bulge through the weak umbilical scale. So when it comes through the umbilicus becomes everted. That's umbilical hernia. And parumbilical hernia, it's just above or below the umbilicus, you will find out. So it's easy to diagnose if you know how to differentiate. Now, spontaneous closure of parumbilical hernia rarely occurs, and they are more likely to incarcerate. That's why you should refer the sort of patient at any age for surgery, preferably after 6 to 12 months. So they need surgery. Umbilical hernia, surgery is not usually required, as most of them close naturally by 4 years of age. But if it still persists beyond 4 years, then you will refer for surgery. But if umbilical hernia is greater than 1 centimeter at 12 months, then surgical intervention is a possibility. Okay, so after 4 years, if umbilical hernia doesn't close, you should refer. So that's your umbilical and parumbilical hernia. Then we have epigastric hernia. An epigastric hernia lies between the umbilicus and the Giphisternum. Okay, so, and it's unlikely to close naturally, likely to incarcerate and cause pain by strangulation. Indications for repair are pain and sometimes cosmetic. Now that's epigastric hernia. In exam, you can get the short of picture. If you look at here, this is the sternum, Giphisternum. This is the umbilicus. In between, you have got this mass. That's epigastric hernia. You can look at here. This is more commonly found. That's in between your umbilicus and Giphisternum. That's epigastric hernia as well. Epigastric hernia more commonly it will get prominent when child cries, coughs, sneezes, or strains. Okay. Also, if you ask the child to raise their head, epigastric hernia will become more prominent. Okay. So these are the main features. Now, I don't know what will be the answer in here. It depends on the picture in the exam they will provide. But because it's just above the umbilicus, it's not umbilical hernia. It could be parumbilical or epigastric. Okay. So depending on what picture you get, now you know that how to differentiate. So just choose the correct one. Next, patient with history of travel since 7 days from Thailand. Now shortness of breath, left-sided chest pain, temperature 38 degrees Celsius, pain increases with coughing and inspiration. What's the diagnosis? So fever, shortness of breath, chest pain, and you can see the pain increasing with cough and inspiration. Okay, so what's your diagnosis? Pulmonary embolism. Because of the travel history. Remember one thing, guys. I know that the travel history is very prompting, but 38 degrees Celsius temperature doesn't go with pulmonary embolism. Okay, so pneumonia will have fever. If you get fever, whatever travel history is there, choose pneumonia as your diagnosis. Now, yes, pulmonary embolism can cause fever, I know, but that's not very common. And usually high fever is not a feature of pulmonary embolism. Low-grade fever can happen. Again, if it is a pulmonary embolism, they would give you more sign, like patient having tachycardia, okay, palpitations, hypoxia. Those are more common. But someone having fever, shortness of breath, chest pain, and the pain increasing with cough and inspiration, anything which involve pleura can cause pleuritic chest pain. Like it could be pulmonary embolism, it could be pneumonia, both of them can cause it. Okay, so unlikely to be pulmonary embolism. Acute pericarditis, having 38 fever, again unlikely. Left-sided chest pain can happen there. Shortness of breath, not common in pericarditis. Okay, pain increases with cough and inspiration can happen in here. But for pericarditis, they would provide you a specific clue that this patient had a viral flu-like illness about a week ago. That's important. And MI is unlikely because having a fever. Someone having 38 fever, don't choose pulmonary embolism. Even now, travel history doesn't mean always it has to be a pulmonary embolism. Okay, sometimes it can be just a drop. Esophageal variceal bleeding, blood pressure dropped to 80 by 45. What is the most appropriate management? So variceal bleeding, this patient is unstable. Patient is having shock, right? Hypovolemic shock. What you should do most appropriate? Propanolol, somatostatin, variceal band ligation, endoscopic balloon tamponade, and PPI. Now, most appropriate in this case should be endoscopic approach. Now, through endoscopic approach, what we do? Not balloon tamponade. Through endoscopy, you do this variceal band ligation. Okay. Now, balloon tamponade we also do, but not initially. I'll just show you the basic management so that you don't forget about it. So very well written in here. Okay, so that's your Australian Emergency Care Institute, New South Wales guideline. Early vasoactive therapy should be commenced as promptly as possible on presentation of the patient who has known or suspected varices. Should not be held pending for the confirmation. So your initial treatment should start with a vasoactive medication. What are the vasoactive medication you have got? Terlipressin, octreotide, or somatostatin. Any of these you should start initially because you need some time to send the patient to the endoscopy and everything. So during that time, patient will get this vasoactive therapy. This patient also needs antibiotic as a prophylaxis. Okay. Endoscopy is the first line in variceal disease for diagnosis and intervention with potential banding or injection. So normally you do either banding or injection of sclerosant. Surgical intervention has little role, but if the patient doesn't respond to endoscopic therapy, normally you can try twice. So initially you tried endoscopy, did not work, then you can try another time. That doesn't help, the next best option will be TIPS. So transjugular intrahepatic portosystemic shunt. So TIPS will be your last option. So in case of esophageal varices, acute bleeding should be managed with endoscopic variceal ligation within 12 hours. Okay. Sometimes you can also use sclerotherapy. Sometimes balloon tamponade is an option, but it's just a temporary option. So after you intubate the patient, balloon tamponade is an option of last resort to temporarily stop bleeding from variceal bleeding when definitive treatment is being arranged. There is complication with that because sometimes this balloon tamponade can cause esophageal rupture. So normally This is not a management. Sometimes what can happen, you tried endoscopy, but you are unable to stop bleeding, so you need surgery. So in between that time, when you are waiting for tips, you can do the balloon tamponade. Okay, so now you understand. So most appropriate management is variceal band ligation. Clear? If they ask initial or next most appropriate, that would be somatostatin in here. I think we already discussed this one. Lady has been traveling in aeroplane after 2 days from United Kingdom, presented with dyspnea, fever of 38.1, chest pain on coughing and on inspiration, auscultation you found crackles. What's your diagnosis? Again, same thing, fever, dyspnea, pleuritic chest pain, again, also crackles, all goes with pneumonia, even though there is a traveling history. 55-year-old patient with a right-sided ptosis, meiosis, and a non-productive cough for 1 month. What is the next appropriate investigation? What's your diagnosis of a 55-year-old patient having a non-productive cough for a month and right-sided ptosis and meiosis? What does it mean? Having right-sided or like unilateral ptosis, meiosis, anhidrosis, enophthalmos, that means patient having Horner syndrome, right? So Horner syndrome with cough or shortness of breath, possible chance of Pancreas tumor, right? So for Pancreas tumor, your initial investigation will be a chest X-ray. First chest X-ray, then you can do a CT chest. Always remember, it's not about a tumor in the lung apex. You can easily find out by doing a chest X-ray. Why you are going for a CT chest rather than not doing a chest X-ray initially? It doesn't make any sense, and never ever you would do it in a hospital or anywhere. Okay, always start with the basic investigation first. Obviously, this patient might need CT chest later on, but chest X-ray will be done as the next one. Years old, let's say 17 years old boy, brought by mother for not going to this school. Yes, CT chest can be most appropriate, right? Not next most. If they ask only most appropriate, then we would choose CT chest. Years-old boy brought by mom with not going to the school, locking inside the room, avoiding social gathering. What's your management for this boy? You want to go for CBT, dialectical behavioral therapy, dynamic psychotherapy, familial-based therapy. Now, if there is anything problem in the family, child will not be in the home, right? They will go outside, they will not come to the home. So obviously, family-based therapy is not a good option here. Same with the DBT. DBT is mainly given for someone having borderline personality disorder, which is not BPD doesn't go with this feature. Then dynamic psychotherapy, CBT, both can be given in here, but always if you get CBT, that's the best option to choose. Dynamic psychotherapy is mainly like sometimes you can give it if CBT doesn't work. Like usually it helps with someone having some internal conflicts. Like let's say a child, like a 20-year-old boy had some history of childhood abuse. Now that part is like the boy cannot remember that or doesn't want to remember that. But in his mind, that part is always there, and that's making internal conflicts and that hampering his whole life. This dynamic psychotherapy helps with bringing up this inherent or covered psychological issues in front so that patient can confront them and patient can deal with them. Okay. Now, usually for someone having this kind of abuse history, we can go for dynamic psychotherapy. But if you get CBT, that's the best option always. A guy in old age home. Yes, dynamic psychotherapy can be used for PTSD. It can be, yeah. But for PTSD, there are more better options rather than going for dynamic psychotherapy. A guy in old age home tried to kill another resident with knife. No previous history of aggressive behavior. What next? So old age home, patient tried to kill another resident. So it's a homicide, right? Or homicidal attempt. So what do you want to do? You want to relocate the resident, refer to the ED, notify police, notify relatives. What's your next step? Because it's a homicidal case, you should notify the police first. And obviously this patient also needs to go to the ED. Yes, if isolating the patient is there, you can choose that. But isolating or confining him is not the most appropriate one, because we are just making sure that he cannot harm anyone else. That would be our initial approach. Then we will try to notify the police so that police can come and then send him to the emergency department. So usually, yes, confine him first, isolate him first, and then inform the police, then refer to the ED. That should be the best approach. Next, 39 weeks, pregnant lady, came with bleeding 1000 ml, tender uterus, fetal part difficult to feel, no fetal heart sound. No fetal heart sound on auscultation, that means this is a IUFD, intrauterine fetal death. Okay. Pulse rate is high, BP low, patient is having hemorrhagic shock. After initial maternal resuscitation, what is next? Caesarean section, amniotomy, ultrasound, syntocinon, prostaglandin. So this case, we already discussed, I think initially, that this patient having placental abruption, but now initial management has been done. Remember one thing, in IUFD, there is no indication of doing caesarean section. Never go for caesarean section because the mother already lost her baby. Okay, and someone having abruptio placenta, their cervix usually becomes very ripened. You don't need to even ripen it by giving prostaglandin or syntocinon. So induction of labor is not even needed. But what you can do, you should go for amniotomy as soon as possible. That's according to your handbook. And even you don't need to confirm it by doing ultrasound, because if you cannot feel fetal heart rate and you did auscultation, no fetal heart sound, and classic presentation of abruption, no need of confirm it by doing ultrasound. Okay, so you should go for amniotomy in this case. If you find out fetal heart sound and in the CTG you can see there is massive fetal distress, then you should go for urgent caesarean section to try to make sure that if you can save the baby. Because in case of abruptio placenta, the cervix is like already ripened. You can, like, we do amniotomy to induce the labor as well, right? So patient doesn't need to be in labor. It's already patient, like we are doing induction to facilitate the labor. Okay. And this exact case is also giving you a handbook. So give it a read in the handbook, you will find it out. Next, moderately demented old patient refusing influenza vaccine when all others in old age home took the vaccine. As a resident physician, what will you do? Sedate him and vaccinate, strangle him and vaccinate. After a week, ask again, don't vaccinate. But in Dr. Fatima, in handbook also they say that the cervix is already becomes like already, I think it's the word was written in this way that the cervix is already like, I think ripen or something like that, that you don't need to even do anything. Like there was option of doing prostaglandin, there was option of doing oxytocin, something like that. Now, someone having cervix dilated 3 centimeters, it's not ripened, right? Usually if it is 5 plus, then we say it's ripened. So in handbook, even with 3 centimeters, they haven't done anything like that. In my perspective, for someone having placental abruption with shock and IUFD, we don't need to go for ultrasound. We don't need to even try ripening the cervix, because already the cervix becomes too much ripened, or you can say like patient already lost a lot of blood. Their cervix usually gets dilated. Yeah, the effacement usually occurs spontaneously in these cases. So usually we don't need to go for ripening in this case. Okay, so moderately demented old patient refusing influenza vaccination while all others in the old age home took the vaccine. As a resident physician, what will you do? You cannot force him, even if he is moderately demented. Nothing is written in here that he cannot decide what he wants or not. Sometimes moderately demented patient understand everything. As long as it's not severely dementia, we will respect his wish. We don't need to wait for a week. Okay, no need. "65-year-old man comes because his wife was diagnosed with osteoporosis. He's having back pain. What is your initial investigation?" For osteoporosis, obviously this 65-year-old man is increased risk. More than 60 is increased risk in men. So he's having back pain. What is your initial investigation for osteoporosis? Bone scan, MRI, vitamin D, calcium, and DEXA. According to your JM, X-ray is limited value, but most useful test is 25 hydroxy vitamin D. Anytime you want to investigate someone for osteoporosis, you should always start with vitamin D first. And you should always treat vitamin D deficiency first before treating someone with osteoporosis. This will be our last case today. So 45-year-old lady with pain and swelling in the ankle. On X-ray, there is periarticular osteopenia, joint space narrowing in tarsometatarsal joints. Tarsometatarsal joint means actually your ankle joint with the tarsal joint, right? So mainly ankle joint, you can say. What can be the diagnosis in this case? Look at the age, 45, lady. All are going for some specific clue. Ankle joint involvement is not very common in osteoarthritis. Now, important finding is this X-ray. If you look at the X-ray finding, loss of joint space is a feature of rheumatoid arthritis. Juxta-articular osteoporosis or osteopenia is a feature of rheumatoid arthritis. And you can read it here. Periarticular osteopenia is an indication of past inflammation around a joint. This can be seen in conditions such as rheumatoid arthritis. Okay, so mainly rheumatoid arthritis causes this periarticular osteopenia, osteoporosis. Osteoarthritis, on the other hand, usually causes like osteophyte formation. So our diagnosis in here will be rheumatoid arthritis. Gout, usually in the X-ray, you will get a punched out lesion or punched out margin in case of gout. Septic arthritis would not cause anything like that. Okay, so that's your main diagnosis, rheumatoid arthritis in this case. All right. So that brings end to our today's session. Do you guys have any question on today's class? Now, as you understand that this is our last class for the free 2-week session. I hope you guys enjoyed our 2-week session. Many of you has already been enrolled, but if still someone wants to join, we will keep the admission open for another 1 week. But you need to make sure that you start processing your payment and everything. Once you start that, then we will add you to our regular classes. Please make sure that if you still want to join, you discuss it with us through the messenger or through our email. Dr. Roy, if that patient with knife comes to the ED, usually it depends. If it's a psychiatric patient, you will start with IM haloperidol because that's the aggressive patient. If it's a patient who is mainly disturbed or having aggression but not psychiatric, then you can try midazolam. Alcoholic patient, they are not psychiatric, so you can try either diazepam or midazolam. Depending on that, if you can give IV, then IV diazepam. If you can go for IV, then go for IM midazolam. Pregnancy with pulmonary embolism, Dr. Moni, you will go for VQA scan, not CTPA. Okay, so that finish our free 2-week session. It was really good to get all of you here. Again, if you want to join, please let us know. Okay, and what else we want to discuss? Those of you who are already been paid for our course, we already added you in a new Facebook group. If you haven't been joined there and you already paid, please message us that you haven't been invited or you haven't been joined, because we already made it about a week ago. The recording of this class will be given in your software, and also the notes will be given in your software. So give it a go from there. Okay, class schedule has been already uploaded in your Facebook group. Thank you, everyone. Have a good night.